Okay, awesome. Well, welcome everyone to our next iteration of the ASCS Virtual Journal Club. Today's topic is going to be on shoulder instability. We have an amazing panel here. I'm going to be joined by our co-host, Jarrett Woodmass, and Dr. Kuhn, the president, is here to poke the bear from our expert panelists. So nothing's going to go by unchecked here. We have Dr. Dickens from Duke University, who's a world expert on posterior labral tears. Peter McDonald from Winnipeg, Go Jets, is going to be talking about his remplissage paper, and then Ivan Wong, who's an expert in bone block procedures. And we're excited to have you all. So before we get going, we're going to get started on, we're going to have a brief word from Smith and Nephew.
At Smith & Nephew, we strive to put solutions in your hands that can allow your patients to live a life unlimited, and the shoulder space is no different. Here at Smith & Nephew, our focus is on providing you options throughout your patient's continuum of care with cutting-edge products like Regeniten, a bioinductive implant that redefines biologic healing for rotator cuff tendon growth.
And the new ATOS shoulder system starring the ATOS Metastem that allows for streamlined procedures, an elevated surgical experience, and efficiency by helping to simplify TSA and RSA. We are honored to support the ASCS Foundation, and it is our mission to continue to provide you with the most innovative solutions in the shoulder space to help restore your patient's ability to live their life unlimited.
Mute.
Okay, so let's get into the first paper. This was by Dr. McDonald, and it was a near paper from, I think, 2 or 3 years ago. The purpose of the study was to compare patient-reported and clinical outcomes between arthroscopic Bankart repair with or without infraspinatus remplissage in patients with recurrent anterior shoulder instability with a Hill-Sachs lesion and minimal glenoid bone loss. Patients 14 years or older with a recurrent anterior shoulder instability with the presence of an engaging Hill-Sachs defect confirmed on CT or MRI were eligible to participate and were randomized into a remplissage or no remplissage group. The primary outcomes were the Western Ontario shoulder instability score. Secondary PROs were collected. Secondary outcomes included the incidence of post-operative recurrent shoulder instability, other PROs, range of motion complications, and revision surgery. 108 patients were randomized to Bankart repair with or without remplissage. The mean follow-up was 26.5 months. Rates of post-operative recurrent instability were higher in the no remplissage group, which were 18% versus 4% post-operative dislocations in the remplissage group. There was no significant difference in patient-reported outcomes between the groups at any time point. Survival curve distributions were also significantly different, favoring the remplissage group. There was no significant difference in rate of revision surgery between groups in 6 in the no remplissage group and none in the remplissage group. Patients were noted to have a higher risk for redislocation if their Hill-Sachs lesion was 20 millimeters in width or 15% of the humeral head diameter. The authors concluded that there was a significant greater risk of postoperative recurrent instability in patients who did not have a remplissage performed in conjunction with an arthroscopic Bankart repair for the treatment of traumatic recurrent anterior shoulder instability with Hill-Sachs lesions of any size and minimal glenoid bone loss at 2 years postoperatively. Otherwise, there is no difference in PROs. The authors also stated that the remplissage procedure has significantly lower rates of redislocation, higher risk patients with Hill-Sachs of 20 millimeters or 15% in size. So Pete, awesome paper. First question, and maybe for some of the fellows here, is 18% dislocation rate recurrence when you're looking at your outcomes. And that's a lot. You just want to comment on that, just dislocation rate for people who are getting into shoulder instability?
Yeah, thanks, Chris, and thanks for highlighting the study. When we started this, remplissage was out there, but there's a few retrospective studies. The best one was by Pascal Boileau, showing reasonably good results, but other authors and speakers were getting up there and saying, I don't think this is going to work out. Remplissage is going to be a bad thing. The soft tissue is not going to heal. There's going to be a loss of range of motion, yada, yada. So we set out to see, we didn't have preconceived notions, but to see if the thing really worked. And we wanted to be fair to the remplissage and not expect it to work in high degrees of glenoid bone loss. So we limited it to less than 15% or really subcritical bone loss. And so these are the 2-year results, and 18% without a remplissage is pretty high at 2 years. And we've since, Jarrett's been part of the medium-term follow-up around 4 years, where it's even higher. It gets up to, if you're strict about definition of instability, recurrent instability, it's up to 30%. So the thing that's important is that if you don't do a remplissage and ignore the Hill-Sachs lesion, then your recurrence rates are going to be unsatisfactory.
Yeah, Chris, I just add to that. I mean, we looked at this and in our military population, all young patients, and yeah, we were upwards of 20 patients with Bankarts alone. So I think the young patient population, start adding on some of those additional risk factors beyond just age alone, and it's very easy to be humbled with just a little bit of follow-up for sure.
Yeah.
Unless your name's Chris Clifto or Jed Kuhn.
I can tell you, I can tell you, looking at our Moon group, our redislocation rate is surprisingly high too. So we obviously haven't figured this one out. Pete, I wanted to congratulate you. This is a huge paper. This is a paper that actually changed my practice, and I think it changed the practice of a lot of people. I do a lot more remplissages than I ever did. Are there people in whom you wouldn't do it? I know you looked at engaging Hill-Sachs lesions, and I want you to define that, because you said sometimes you determine that based on an MRI. So tell us how you defined the engaging Hill-Sachs lesion to be an inclusion criteria, and then tell us who you do remplissages in.
Yeah, thanks, Jed. I have a hard time with that term, engaging Hill-Sachs, because to create a Hill-Sachs, it had to have engaged at some point in time, otherwise it wouldn't be there, right? So we start off with that in the initial intention, and then we got into thinking, well, all Hill-Sachs lesions must have engaged at some point in time. So we got more liberal with our inclusion rates. As long as the glenoid bone loss wasn't critical or greater than 15%, that's what we started to get sticky about. But we started including all sorts of Hill-Sachs lesions. And what was your second part of your question?
Well, sometimes I'll get in there and I'll see a Hill-Sachs lesion that's there, and it says, well, this might be important, so I'm going to remplissage it. And sometimes you get in there and don't see much of a Hill-Sachs lesion. Is that one you can let fly? I mean, how do you clinically use this data now? What Hill-Sachs lesions will you do the remplissage in?
Yeah, I mean, obviously, since the study, we'd be more aggressive in doing ramplissages. At least I have in my practice. I'll do it whenever there's a Hill-Sachs lesion now. I think that if you're going to do a Bankart repair, and now modern techniques, modern anchors, knotless systems, you can do it in 10 minutes once you get used to it. So there's no reason not to do it. We haven't found a significant loss of range of motion, so I just do it in anybody who's got a Hill-Sachs lesion.
I love how Canadians say glenoid. Pete, when you're considering glenoid abnormalities and bone loss,
How am I supposed to say it?
I don't know. That sounds weird to me. But what factors do you consider? Do you consider the anterior bone loss when you're doing a remplissage?
Yes, obviously it's an analysis that we'll do with advanced imaging pre-op, and if we see critical bone loss, I'll go into a bony procedure.
Sorry. So one thing I find, this paper is awesome, obviously. But my biggest question then is, when do I not do a remplissage?
Yeah, I think I'm doing it on any case where I see a Hill-Sachs lesion now. I don't see any reason not to do it.
Do you mind expanding on the comment about the technique? So I know there's different ways that you can do this, but if you're doing it under 10 minutes, can you just briefly outline how you approach these?
Well, it might take you 20, Jarrett. No, just kidding.
30.
No, I mean, without getting into which companies we're using, we use knotless anchors now. We don't, initially there's always a question of whether you should go into the subacromial space, take a labursa away, visualize the actual procedure working and the knots coming down. So we started off, with knots, but now we've evolved to a knotless technique. I don't go in the subacromial space. I just put the cannula through skin and subcutaneous tissue, try and clean it off blindly. subacromial space, and then put the anchors in close to the margin of the articular cartilage, although not right on it, and then space them out a good couple of centimeters and do a knotless remplissage that way.
Yeah, I think John Kelly had a nice paper about kind of the safe zone, obviously trying to stay lateral. And I think that's something I always go back to. And kind of the key points to that are trying to stay 1 centimeter lateral to the lateral border of the acromion, and then within 3 centimeters, so less than 3 centimeters below the acromion. And that if you're in that safe zone, that sort of keeps you lateral, so you're not over plicating and losing your rotation after these. So that's always something I look at externally when doing these.
Yeah, the other thing we talk about a lot is the order, and we'll put the anchors in, but we won't tension them down. Put the anchors in first with the scope in the anterior superior portal, visualizing the Hill-Sachs lesion. I roughen it up a little bit to stimulate healing. Put the anchors in, don't tension them down. Put the scope back in the posterior portal, do our Bankart, and then tension down the remplissage anchors at the end.
For those of you who haven't seen this, Pete has a great technique video in the shed on exactly how he does it. So check it out. It's awesome. So for the panelists, let's say you have an athlete, right? Or John, you are like one of the world's expert on military instability. People who are high functioning need to have more external rotation, say. Are you still doing a remplissage in this patient population? Maybe we can start with you, Ivan.
Well, so right now, this is my problem. This is why I'm asking Pete. When do I not do remplissage? And honestly, every data out there shows that they regain their range of motion. Everyone talks about this loss of range of motion, and honestly, with soft tissue fixation, the range of motion seems to come back. Even we talk about Bankarts, if you get them enough stretching, they all come back. And I think that's the reason why we see failures in soft tissue fixation happen, increasing year over year, right? So 2-year follow-up, you see whatever rate, but they keep increasing as compared to a bony fixation. So I'm really not worried too much about getting them too stiff with a remplissage, as long as I don't tie that down, as long as I make sure I follow what John just talked about, doing in the safe area, not tying down too much infraspinatus. And as long as they follow their rehab protocol, they can get that back. It might take them a little bit longer if you tighten them too much, but they will get their range of motion back.
I have a question for Pete. So getting back to your paper, you powered it for the WOSI score, which is great. You really didn't see a difference in the WOSI scores. But you did have a higher dislocation rate. And how we define failure of these operations is all over the literature. I mean, sometimes it's a dislocation, sometimes it's a subluxation or a dislocation, sometimes it's a feeling of apprehension. You probably didn't collect this data, but do you think doing a remplissage would reduce those other outcome parameters like feelings of subluxation or feelings of apprehension?
Yeah, actually, in our medium-term follow-up, we broke those down, whether it's recurrent dislocation or recurrent instability symptoms. And actually, Jarrett, you may want to comment on that because you teased that out nicely.
Yeah, we saw about 25% more people. So if you look at subluxations, we define it as instability was a single dislocation or 2 or more subluxations that a patient experienced. And there was a significantly higher number of patients who were experiencing subluxations, even though they hadn't dislocated their shoulder in the no remplissage group.
Out of curiosity, so we talk about doing remplissage in almost any time you have a Hill-Sachs. Is there a Hill-Sachs that's too large to just do a remplissage?
Yeah, well, that's the other finding in the paper. If the Hill-Sachs lesion was greater than 20 millimeters in width or greater than 15% of the humeral head diameter, then the recurrence rate was higher. So those were what we called at-risk patients. They still did well with remplissage, but you start to get into, I think if you get into greater than 20 to 25% of the diameter of the head involved, you have to start thinking about doing something different on that side too.
Can I just ask the group, just because we have great articles, some of them don't talk about, or many of them don't talk about open Bankarts as much. And if we look back at some of the original early open Bankarts and, Pagnani's work, 2-3% recurrence in American football players. This is sort of before we knew what we know about on and off track and hill sacks, does anyone do an open bank hearts? And what's your tolerance for ignoring a hill sacks if you're doing an open bank heart? Because it seems like we might be able to do that with the open bank heart vice doing it arthroscopically.
Yeah, it's interesting. When I first started practice, of course, I trained with Rich Hawkins and did a fairly large number of open bank hearts at the time. And he always said, just ignore the hill sacks lesion, it'll be fine. We didn't even tease out glenoid bone loss in those days until Burkhart and De Beer came along with their article. So I think the reason open bank hearts work is not only you're repairing the labrum, but you're also doing some sort of capsular procedure to limit external rotation, which we don't find that desirable anymore in terms of the athlete and high level function. So I know Bob Arciero is a big proponent still of open bank heart, but I phased it out of my practice.
I think I trained just a few years behind Pete with Hawk as well, and we were just transitioning to arthroscopic bank hearts, and we weren't very good at it. And I think Pete's comment is worth repeating, and that is if you do an operation that limits external rotation, you're not going to be able to engage, and in that circumstance, you can ignore the Hill-Sachs lesion. But if you're doing an operation to try to restore full motion, then the Hill-Sachs lesion will be able to engage, and that's where a remplissage may be necessary to prevent those symptoms of instability.
All right, awesome points. Well, you're making me feel bad about myself because I had a hill sacks today. I didn't do a remplissage, so perfect. One quick thing, everyone else, there are a lot of great people here in the audience today. And if you have any questions, put them into the chat. We'll make sure to read them out so all your questions are answered. All right, Jared, want to go to the next one?
Yeah, so I think this is actually a good transition because even in expert hands, we have 20% failure rates for a lot of these procedures. So next paper looking at risk factors for failure of arthroscopic revision after anterior shoulder stabilization. So the purpose of this paper was to evaluate the outcomes after arthroscopic revision anterior stabilization for recurrent instability after a failed index procedure. It was a retrospective case series. 92 patients had undergone revision, 65 of which were available for a 2-year analysis, and the mean follow-up was 4.7 years. So glenoid bone loss was measured using best fit circle method, and there was 51% of patients that had their index procedure outside of the institution before coming in. They used standard suture anchor stabilization. No remplissages were performed in any of these cases. And for the results, so 42% of patients had experienced recurrent instability at an average of 2.3 years. 18 patients underwent a second revision surgery. 10 of those second revisions were also soft tissue. It's noteworthy that 23% of the patients had no labral tear at the time of revision, and they did include patients with hyperlaxity in this cohort. So risk factors for revision included the presence of an off-track lesion, young age less than 22, or ligamentous laxity. And if you teased out that group, then the failure rate reduced down to 19% when those patients were excluded. So the conclusion of this paper was that arthroscopic revision, anterior stabilization, is associated with a high rate of recurrent instability, but with good patient selection, the critical importance of good patient selection in order to minimize this recurrence. So when we look at some of those numbers, I think one of the first things that I wanted to address, and maybe Ivan, you can take this, patients with hyperlaxity, are they treated the same, or how do you tease that out right off the start?
Yeah, I'll tell you, that's one of the hardest things to do. That's where I think the art of medicine comes in. You want to look at every aspect of it that you can. So again, a history of it, family history of it, if it happened without trauma. So I'm trying to look for anything that is kind of out of the usual that would suggest this. And then of course we have the Baden score. We have the external rotation down by your side with the arm, and those are really all you have to go with. If we make that decision to go, a very big thing I want to make sure is that we get them as strong as physically possible. That's with their lax, their multi-directional instability, or anything along those lines. So we actually spend a lot of time now focused on dynamometer measurements, trying to make sure that they're actually equal on both sides, as strong as they can be, no scapular winging, so that they get a good chance outside. Because I find when we're in for surgery, we can actually see laxity much better. That capsule looks thin. You can drive your scope through. So I really find the intra-articular diagnosis is the best one to do. We just need to be prepared for it before. That's where the counseling comes in. And that's as much as the pre-op work that you can do to get them strong and prepared for this, especially in our Canadian healthcare system, where we usually have some time to get them ready before surgery. Same thing as after surgery. So after we do this, it's really important, once you have a concern for it, to be able to let the patient, the therapist know that, look, this person's more lax. We would change how we do the surgery as well. Obviously, I'm more inclined to do remplissage, soft tissue, inferior to superior capsular shift using the techniques we do with our bone blocks, and being very careful to pay attention to any subtle bone loss there is, because patients with hyperlaxy do get bone loss, and those patients with hyperlaxy, even a small amount of bone loss affects them even greater than those people with a traumatic history of a dislocation.
And maybe over to John just for a moment. When you're looking at these numbers and a 44% failure in revision, like when you're doing revision soft tissue, what role does revision soft tissue repair play in your practice, or are there other options or treatments that you typically go to?
Oh, you're mute.
Just unmute.
I'll get it eventually. So first, I think it's a really important paper, and we've had similar numbers in our series of revision arthroscopics. And then if we did look at our revision Latarjet patients too. So we compared our primary versus revision Latarjet. And I think what's important here is, regardless of the bone loss, the bone loss wasn't what was predicting the failure. And so that, to me, points my mind that there's a capsular issue here in these revision patients. Whether you're doing a revision in a Latarjet, which for us had a revision Latarjet had twice the failure rate as a primary Latarjet. And so this revision arthroscopic Bankart repair, numbers over 40%. That's kind of double what we were just talking about with the arthroscopic Bankart from Pete's study. So I think the number one thing is the capsule is probably overlooked in a lot of these, and it's, I think, even more problematic in the revision study. And if we look at the biomechanics, like there were some early biomechanics studies that were done, and John Ticker did them, and some of the other folks. And if you just had one dislocation, you had about 10 millimeters of permanent deformation, but you can get that back arthroscopically. If you have multiple dislocations, you get more elongation of the IGHL, and you have a harder time correcting that arthroscopically. So that's kind of, I think, the key take home from me with regards to kind of the capsule management. Personally, this is where I think an open Bankart for me really becomes a little bit more of a opportunity to shift that capsule, close the volume, because I can probably manage that a little bit better. And the last thing I would say is that Buddy Savaw and Mike McCabe did a paper on revision Bankart with remplissage in the revision setting. And in the revision setting, the remplissage had twice the failure as the primary remplissage. So it seems to be consistent revision procedures. We probably need to be thinking a lot about the capsule.
I'll make a few comments. This paper's okay. It's not going to change my practice much, I think. It's a case series. It's at one institution. Whenever you talk about revision surgery and approaching revision surgery, there's huge selection bias, because there's probably a ton of people that they revised with Latarjets or bone grafting or other techniques. So they've selected out the ones they thought would do best with an arthroscopic approach. And still they had a very high failure rate. And the features, as you mentioned, that cause failure, that are associated with failure, are younger age, off track, and ligamentous laxity, which are the things that predict recurrence after a first dislocation. So I don't know if this is going to change my practice. If I see a young patient who is off track and has ligamentous laxity, I might not even try an arthroscopic Bankart for my first operation. I might go right to the Latarjet and say, why even try an arthroscopic Bankart in that group? So I think it's a helpful study, but I don't know if it's going to change my whole practice a whole lot. I mean, I don't, if I have to do a revision and I see somebody with those three features, I'm not even thinking arthroscopic for most of those.
Awesome. We have a question from the audience. For the hyperlaxity patients, stabilization surgery after appropriate prehab, what tips, tricks, pearls would you advise it for surgical technique? Prefer number, types of configuration of anchors, remplissage, any other capsular augments that you would recommend? Ivan, you want to take this one first?
Sure.
Maybe go right down the panel.
That sounds great.
Pete,
So
you're next.
yeah,
You're not going to pass this one.
again, very difficult problem. Anyone with hyperlaxy is always worrisome. So it depends on for first, second revision, that kind of stuff. Essentially, anyone who's hyperlax, you're worried about Ehlers-Danlos, something like that. We start off very carefully talking that this likely is going to be a lifelong problem. I'm going to see you multiple times, or you're one of my colleagues, because if we're doing a soft tissue fixation, there's no bone problem. It's going to stretch out again if you get weak and if you don't protect that shoulder, if you get another injury. So we just have to commit down to that problem. Will likely solve the problem for a bit. Patients do well for a while, and everyone just depends on how long they last. If they're okay with that, then I want to take a stepwise approach, because I don't want to take out all the tricks right away, because if we run out of tricks later on, we're heading down to a fusion way too soon. So first thing is we do the things that we know. We try to loosen all that tissue inferiorly, anteriorly, posteriorly. I add everything we can for a capsular repair. So, remplissage, start at 7 o'clock, shift the tissue all the way up, close down the rotator interval. So I do everything I can to make sure that happens with lots of anchors. Whatever technique you use, I don't think that really matters. As long as they're strong, they protect it, because down the road, we're looking at multiple things. So in a revision setting, after we do that, I'm looking at different types of capsular reconstructions. We've done our presentations or publications on anterior, posterior capsular reconstructions using dermal grafts, and they work. And now looking at them 7-8 years down, some will still fail because they again, soft tissue is soft tissue. They do heal for a while. We have MRIs to show they can do, but we just need more bags of tricks to get them through to the 40s and 50s, where they start stiffening up, and then that doesn't become a problem anymore.
Pete, do you want to make a comment on that? I know you have some experience with Achilles
Yeah.
allografts in these cases.
Yeah, I think that first of all, you have to define your terms. Are you still talking about traumatic instability with a Bankart lesion in somebody with a little bit of hyperlaxity? Or are you talking about a multidirectional instability situation in somebody who has got borderline Ehlers-Danlos? So first of all, you have to sort all that out, because the approach to those two are different. If they have a Bankart lesion, then there's been a traumatic component. I think it's still reasonable to try an arthroscopic approach in my hands, and then do a more aggressive capsular part of the procedure, not only remplissage, but tighten up to the 7 o'clock position posteriorly, and so on. But if they're a true MDI, Ehlers-Danlos type picture, then obviously, as Ivan has outlined, it's going to be a real difficult situation, and you're probably looking at very high recurrence rates no matter what you do. We have done some Achilles allografts, but in those people who are true Ehlers-Danlos, they have multiple joint problems. I tell them to expect another operation about every 5 years. So kind of have to temper their expectations.
I will make one comment on this. Vanderbilt, unfortunately, is a place where they genetically test people for Ehlers-Danlos. And if they mention to the genetics testers they've got shoulder problems, they end up in my clinic. And that's a problem. I think the point I would make is Peter's comment that if they have a traumatic component to it, you can kind of get them back on the ledge by fixing the traumatic damage. But the real answer for all these people is rehab. And one of the things that I've seen in my practice is somebody will operate on them and they don't do well, and they operate on them again and they don't do well, and they operate on them again, and they kind of fall into this deep rehab hole. And I'm talking about the Ehlers-Danlos patients. And for me, the answer is rehab, 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 and then more rehab. And I think if you keep whittling away at them and they get weaker and weaker and weaker and worse scapular control, they just have worse symptoms. And finding a good therapist who can handle these Ehlers-Danlos patients and knows about scapular dyskinesis and knows about proprioception can be a lifesaver. But it will be it's a marathon. It's not a sprint. It's a long rehab recovery after a surgery like this.
Yeah, I would just reiterate kind of what's been said. I mean, I think laxity is on the spectrum of normal, especially for these patients. Instability is traumatic. And so just kind of like everyone's just said, just defining those. And I would just say for those lax patients that do have instability, or you're doing an MDI operation, a balanced repair, so anterior and posterior is very important.
I think one of the other things to look at is, when we talk about a remplissage in those people with laxity, they tend not to have a Hill-Sachs lesion. They tend not to have any
Right.
lesion in there. It's just so patchless. And then, when you're in there, you're in for trouble.
Well, you heard it here first. Send all your EDS patients to Vanderbilt to Dr. Kuhn's clinic. All right, so we'll go on to the next paper. You're president. You're the president. You have a higher standards. Okay, so next one is on posterior shoulder stabilization. So the purpose of this paper was to determine the objective and subjective clinical outcomes of shoulder function after arthroscopic posterior shoulder stabilization at a minimum of 10-year follow-up. This was a retrospective review of 53 patients with unidirectional recurrent instability who underwent arthroscopic limb repairs at a mean follow-up of 15.4 years. PROs, pain, range of motion was collected at a minimum of 10-year follow-up. Outcomes from the same patient cohort were previously collected at 3-year follow-up and were evaluated for longitudinal analysis. Subgroup analysis for sport type, throwing status, revision status was performed. Risk factors for revision surgery based on MRI findings, patient characteristics, and surgical findings were investigated. Arthroscopic labral repair for posterior shoulder instability led to statistically different improvement in all outcome measures with similar values at 3 and 15.4-year follow-up. 34 returned to sport at the same pre-injury level, 60% returned to sport at some level. At long-term follow-up, 28% had to discontinue sporting participation because of ongoing shoulder issues. Throwers trended toward lower PRO scores than non-throwers, but had improvements. Contact and non-contact athletes had similar preoperative and postoperative values with equal improvement in surgery after. 35% of patients were defined as failure based on revision surgery, ASCS scores, or stability value scores. Overall, 13% underwent revision surgery. At long-term follow-up, patients who underwent revision surgery had worse outcomes than those who did not undergo revision. An acute injury in the postoperative period and smaller glenoid bone loss was indication for revision surgery. The authors concluded that arthroscopic posterior labral repair for instability was a durable treatment option with improved long-term shoulder pain and function and facilitated return to sport. John, first question for you as the posterior shoulder guru. Do you agree with these authors' conclusions? It seems like these are pretty high failure rates and low return to sport.
I mean, if Dr. Bradley is having these failure rates, then I think we're all doomed to have some less than desirable outcomes. But I think, this is a long-term follow-up study. And so 10 years is a long time. And so you might expect this to have some degeneration. I think what's interesting is what's kind of opened my eyes recently is, and Christian Gerber kind of introduced me to it, was the acromial morphology. And so a high flat acromion, that's not going to provide kind of this check range. So, if you're coming out the back and you have this oblique acromion, that might provide some secondary kind of chalk block. But if you're high and flat, then certainly that can continue to happen. And so Gerber's first paper was that the B2 glenoids had a high flat acromion. And then his second paper is these patients that have posterior instability have a high flat acromion, and we've found that in ours. So maybe that's what we're seeing here. We also, and this is in Bradley's study, comments that, we weren't really looking at posterior glenoid bone loss then. We still don't know how to look at it. It's different from anterior. It's more inferior and oblique, as opposed to being perpendicular to anterior. It's more of a delta kind of tangential away from it. So there's a lot to learn with posterior instability, and maybe some of these had some posterior bone loss as well. So a lot to learn. It's probably to be expected that we're going to have some high failure rates, I think, especially in a push-up population or someone who's doing repetitive kind of bench press and those types of activities.
I'd like to make a comment, Chris, and this is something that I've seen in the literature that I get confused by. So I'll ask the panelist, is someone who has a painful posterior labrum tear, but no sense that their shoulder is slipping, do they have posterior instability? Pete?
Yeah, I mean, interesting question. You certainly don't see recurrent posterior dislocation very often. You see recurrent posterior subluxations. Sometimes, as you said, you see isolated posterior labral tears. I think for purposes of this, we've thrown them all together, but I think, again, you have to get back to defining your terms. I classify that as a posterior Bankart, so I think there's a degree of instability, but you're not seeing the same degree of instability as you do anteriorly.
John, like when you look at your patients with symptoms and they have a painful posterior labrum tear and you fix that, the literature to me says that those patients actually do pretty well. It's the person whose shoulder is falling out the back that has higher recurrence rates and more problems. Would you agree?
Yeah, I would agree for sure. And you know, if we have a hard time defining subluxation and dislocation anteriorly, it's a mess posteriorly. And so for me, the painful posterior shoulders that are not dislocating, but they have a jerk or a Kim, to me, that is the symptomatic posterior instability. And that's kind of my indication that they have a truly kind of clinically symptomatic posterior labral tear.
So my take on this is I would not define someone as having instability unless they have a feeling that their shoulder is falling out, slipping, translating, moving like an unusually fashion. If it's pure pain, I can give them a pretty high success rate with a posterior labrum repair. Even though maybe the shoulder slipping created that labrum tear, the patient doesn't perceive the sensation of instability. That's a home run. I think those patients do really well with an arthroscopic Bankart, posterior Bankart repair. It's the unstable ones, the ones who actually feel like their shoulder's falling out, that we have high recurrence rates on and haven't really solved yet. And the literature, unfortunately, combines those two populations, and I don't know if it's appropriate to do that.
Yeah, there's another population, Jed, that you're probably aware of that don't do well, and that's the ones who have a chronic posterior labral tear and they develop fixed subluxation of the head on the glenoid posterior and they develop chondral wear posteriorly. Those patients are really tough in my hands.
I think that's a spectrum though, because one thing that we're not looking at, even though they do be painful and they're not instability at that time, if they have a bit of a wear, a little bit of attritional loss, we repair the Bankart, or we repair the posterior labrum, and they feel better. But over time, they lost that bony support, so they're the ones who I think tend to fail. Part of what the reason is we weren't doing as many 3D reviews, right? CTs, looking carefully at the bone, because it's really a 3D reconstruction. You'll miss this on a 2D reconstruction looking at axial reformatting, because if you're just off axis, you won't see that slight erosion in the back. And if we leave it long enough, I really think that's the progression to that static posterior subluxed humeral head that we really want to avoid.
Yeah, in fact, it's probably the very beginnings of the B2 glenoid. Come back in 20 years and you got a B2 glenoid, right?
Hey, do you have any tips for how to correct that? Because like early in my career, I had patients that had slight subluxation. I tried to correct it, recenter the humerus, have failed, and they all have developed post-instability arthritis. Any tips early on to try and recenter the humeral head? Is it possible?
I mean, it's very difficult in my hands. I don't think I've ever successfully convinced myself that I could do it. I think the best answer is prevention. Get in there before they have that fixed subluxation and correct their posterior Bankart.
Has anyone been successful?
Just follow up on that, maybe to Ivan. Is there like a degree of posterior glenoid attrition or bone loss that would make you do a bone block? Like what is your threshold to say, I'm going to put a bone block and not do a primary posterior labrum repair?
I'll tell you, it's bone blocks. Again, I like bone blocks. They're working well, and we've done lots of great stuff on the anterior. Now we're looking at the posterior because that seems to be the same story. You know, the number before was 25% anteriorly that you start looking at bone block procedures anteriorly, not doing Latarjet. Posteriorly, that was the same quoted number. And I'll tell you, same story now. You start seeing a little bit of erosion. You start losing that. In fact, what I really use is Marauder's depth of glenoid. When you lose that depth of glenoid looking across an on-face 3D reconstruction of the glenoid and they're coming out posteriorly or having a posterior labral tear, they are losing that edge. That last millimeter of bone that rises back up. Once you lose that, that's where you start going down that slippery slope. And that's when I really start considering doing some kind of bony reconstruction. And for me now, the real telltale sign is once I see flattening, so the glenoid should be round at the bottom 2/3 of the glenoid. Anytime I see flattening, some straight face in any plane, they have bone loss. We may not be able to measure it. We not be able to draw a perfect circle, but we need to start paying attention to it because it's going to see us.
And are you doing CT scan
Yeah,
follow-ups, you or John, on these patients? Do you get resorption similar to anterior?
for the bone blocks. Yeah. And I think Ivan's got good data on this, especially anteriorly. I was just going to comment for me, posterior bone blocks, my indications now is not a primary procedure. It's only a select handful and it's less than 15, but it's a revision procedure. And they have to have bone loss more than 10 to 15%. I actually worry more about a larger amount of bone loss, and I haven't had this problem yet because I feel like that's going to be one where their whole humerus is going to rest on that bone block and be. I worry about the wear of that bone block if they're in that fixed humeral head subluxation position more. But yeah, I get CTs and fortunate to be able to get some 3D modeling here preoperatively for planning those, but postoperatively getting CTs as well.
You know, it's interesting looking at the long-term outcomes here when you're going out 15 years. Like patients are getting, you know, a fair bit older. We sort of touched on arthritis, but maybe Pete, do you want to comment on like, when in your practice, are you seeing these patients develop to arthritis, or is that a myth that posterior labrum tear becomes B2?
No, I think it's an actual thing. In fact, I've ended up doing arthroplasties in a fair number of these patients in a relatively young age, because I had no other answer for them. So I do think it's a progression over time. And I think, didn't you have a study at one time looking at this, that if you follow these posterior labral tears long term, that there's a high percentage of arthritis?
Yeah, we looked at the data at Mayo, and it showed that if you debride a posterior labrum, like when they're doing repairs, they had done reasonably well, but any tears that had gone in and you're doing a debridement, that there's a pretty high rate of conversion. So, you know, same thing. It's probably, you know, you're there for pain, but it's like the meniscus tear in the knee. It's just the first step.
We're getting some questions from the audience, and I think they want to hear from all the panelists about any tips for controlling posterior subluxation operatively if anyone has any success. And maybe we can start with Ivan.
Sure. So tips for posterior subluxation. I think we talked about how you got to look at it. Actually, I like looking at pictures. So we're just going to switch over. Can I do that? Yeah, here we go. So 3D model is something I always use. If we look at it, these are really for anterior because most people ask me about anterior. But if we're looking posterior, you look at the vertical plane of the long axis of the glenoid, it's always slightly anterior. And when we look at anterior bone loss, you can see here, the anterior bone loss here is very parallel to this. Posteriorly is not the same. John was talking about it. It's off at an angle. It's almost 45 degrees sometimes, but it's really based on the shape of the acromion. And the acromion really changes. So if you look at this patient, it's easiest to see if you look at it on face. So if I look at it in line with the glenoid face, just look at the acromion here. It's a round back. If I look at it from front to back, it doesn't actually cover very much of the posterior glenoid. I'm just trying to show you the best I can from this. It comes at an angle. Whereas this patient, if you look here, has a very sharp corner. It comes very posteriorly. So I got to look at the shape of what goes on to be able to identify, is it a bony lesion? Is it not? So if the angle fits for where it was subluxed posteriorly behind the acromion, then I'm actually worried that it's a bony problem. If it does not have anything to do with that, meaning there's no cysts in here, the concavity is actually very important. I'm going to look at it this way to make sure I still see that concavity. It should be a 2 to 4 millimeters sunken in the very center. Then I'm not worried about bone loss. So if I see some, then that's the decision to make. When it's only 1 to 2 millimeters, I agree with John. I probably would not do anything, but this is somebody who I'm going to follow very closely. And if they're starting to have failure or starting to have problems, I'm going to revise this to a bone block pretty quick. But if they're losing about 3 millimeters, again, 3 millimeters is 10% already, I'd still be changing that out to a bone block pretty quick.
But Ivan, to John's point, like when you put the bone block in, aren't you just going to have the head articulating now with the junction between the bone block and the native glenoid, and that bone block's going to maybe break down more often than anterior?
Yeah, so we're not finding that when we look at this. If we can recreate, so this is the thing that I realized. Before, when we're trying to recreate a bone block, we wanted to make it perfectly flush, flat with the glenoid, but the glenoid's not flat. The glenoid is concave. If you can recreate that concavity, and arthroscopically, it's actually an easier way to do that because the switching stick has a nice angle to it. If you look at that sharp point at the very end, it looks like a pencil tip. If you follow that, that angle seems to work out nicely. It does articulate with the bone, but you're going to repair the labrum on top to make that dish formation again. If you make that dish, it actually centralizes the humerus on the glenoid.
Okay, well, I guess Ehlers-Danlos to Dr. Kuhn and posterior subluxation to Dr. Wong. Okay, we're going to move on to any other comments about that, or are we okay to move on to the last article? Good. Okay, so we're going to discuss outcomes of Latarjet versus distal tibial allograft for anterior shoulder instability repair, a matched cohort analysis. So the purpose of this study was to compare distal tibial allograft in a matched cohort to Latarjet. This was done at Rush, and they have quite a robust prospectively collected database, and then looked at this retrospectively. They took all patients with greater than 15% bone loss who underwent either a Latarjet or a DTA with a minimum 2 years follow-up and matched them 1-to-1 for age, BMI, history of contact sports, and their number of previous operations. And they looked at SST, VAS, ASES, WOSI, SANE, and the complication rate. So they found 100 patients. So there were 50 DTAs that were then matched to the Latarjets, mean of 45 months of follow-up. 2/3 of these patients had had a prior surgery, and bone loss was significantly greater preoperatively at 28.6% in DTA and 22.4% in Latarjet. So in their methods, they mentioned that typically the DTA in the early days was reserved for patients with 25% or greater bone loss. Their outcomes showed no difference in ASES, SANE, VAS, or WOSI. They did have higher SST scores in the Latarjet group, similar complications with a total of 10% and a 1% recurrence rate. So the conclusion was that DTA reconstruction results in a clinically stable shoulder with similar clinical outcomes to Latarjet. So maybe before we get into some of the details, Ivan, I know you do a lot. You've kind of been a champion with DTA. A few years back, I'd done my first one, and you did a educational session where you could actually live go into your OR with the headset on and talk someone through. And it's actually really nice to get some of those tips and tricks. You want to share a couple tips and tricks with the group on your approach to these?
No, absolutely. Bone blocks, this is a great study. The bone blocks is just important to get what you want out of it. Because again, the reason why it fails is you lose that strength and support, and you want to be able to recreate the bone where you want it. And honestly, this is all imagery. So let me just switch back over here. It's easiest to show, this is a post-op CT. Hopefully you can see where it's actually created. You can see the bones actually recreated here. We put a rectangular piece of bone. Again, why do we put a rectangular piece of bone for a distal tibia? Is really because we can put 2 screws in here consistently. So that's the only reason. You can see after a couple of years, it doesn't become square or rectangular anymore. It then becomes rounded for whatever pressure it goes on. And you can really tell that's the case because if you look at it from the axial view, it's not rectangular here. You can actually see how it's recreated this curvature following the normal shape of the glenoid. So the whole point of doing a distal tibia or a bone block technique is to be able to get the scaffold in here so the body can remodel it back to a normal shaped glenoid. It's not going to be rectangular. It's going to be round. It's going to see everything that sees pressure on it. So the things that make it difficult to go in, and that's what they talk about, is to get the graft in the right position. And the graft in the right position is low enough to recreate the shape because that's where the pressure will come in, and then flat enough as well as concave enough. So hopefully you're seeing this in this view that we have recreated the concavity in this too. And I think that's where the advantageous of doing it arthroscopically is we can actually see this. The paper over here, actually, I can share that too. How do I share that? If I go to screen 2, this is really interesting when you look at how they do it here. They have gone in to do the open surgery, and with the open surgery, this is all you can see. I know it's a small screen over here, but that's all you can see for when you go into to do open surgery. But this is what you recreate. So if you get a good fixation, they're doing the same thing. A good fixation will get that round curvature back and get that remodeling to the same shape. So you can do this open, you can do this arthroscopic, but the most important thing is get low enough, parallel enough, and recreate the concavity. And with open and arthroscopic, different things. Arthroscopically, you have to get it lateral to the conjoint, superior to the subscap, and get the appropriate releases. We've done all our papers to show you that it's possible, but really now with all the technology that we use, we teach this virtually, is we show you all the releases you need to do. And honestly, people just watching virtually, I know you did that with me, Jarrett, it makes it pretty obvious. We can do this virtual cadaver lab too, that you can learn how to do this technique and never have to leave your own center.
Well, in this paper, they did both techniques open for the lateral J or distal tibia. Maybe we should just, throw this out to the rest of the panel. Are these techniques equivalent? You can use either, and do you do them open or arthroscopic?
Can I make a comment, Jarrett?
Please.
This paper cannot tell you if the techniques are equivalent. The problem with this paper is something we see a lot in papers that are submitted to JSES, and that is when they go back and hit a database and they do multiple comparisons, the likelihood that some of these p-values are going to be significant becomes low, and it may be underpowered. They powered this study to look at external rotation, which they don't even talk about in the paper. So, no offense to Rachel, she's a great friend, but this is not a great paper to tell these are equivalent techniques. Now, personally, I believe they both work great. They're great for recreating bone loss, and which one is better, I can't tell you. I know which one's cheaper, but I can't tell you which one's better. So I think you can use both and use whatever works best in your hands. Ivan can do amazing things arthroscopically with bone blocks. I don't know if I'm that qualified. For me, a lateral J works better in my hands, and it's cheaper. But I don't think you can use this paper to say they're equivalent. I think you can use this paper to say they both seem to work, but they may be underpowered to show that one is better than the other.
Yeah, and with the matched cohort, you're always going to have, and I think you alluded to this, Jarrett, there may be a preconceived bias towards the worst types of instabilities having the bone graft rather than the lateral J. So the indications for both, excuse me, were probably different.
So I agree that you can't tell the difference between one and the other, but I kind of applaud them because the most important thing is there's very few papers out there that actually compare a technique from actually the same center. So even though this is not a great paper, this is probably one of the best papers out there to show where distal tibia and lateral J kind of come head to head, even with different patient populations. And with that information, at least we can say that, look, Matt Preventure, really spent time to look at the distal tibia, see if it will work. And with all that basic science that he's actually gone through and the mechanics and whatnot, even the systematic reviews, it does seem to play out that, look, yeah, it may be equivalent, and that's a good thing. We can actually take it to the next level. It's worthy of further study to see where it can go. My only problem is, distal tibia, the only advantage to do distal tibia is potentially on massive bone loss because we're doing it both open. The failures are the same risk because you're doing it open. You still expose all the nerve. You still have to do a subscap. Their failure is a subscap failure and a musculocutaneous nerve transection. So those are the reasons why I don't like doing open surgery. I'm not as good as Jed is. I like arthroscopic because I'm so far away from the nerves that I feel comfortable teaching this virtually.
Well, you Canadians are really good at randomized trials. I think it's time to do one.
Ivan, are you using fresh? Are you using frozen? What kind of graft are you using?
Yeah, so this is the other thing. Canada, or actually Halifax, I don't know what Pete can get or Jarrett. I can't get fresh. I can only get frozen. We're a local bone bank, so they're all frozen. They're just sterilely harvested and frozen. I don't know how long they've been frozen for, but lately everyone's been requesting our distal tibia. So I only have one left in the freezer. We used to have so many that I could do as many of these as I want. We're actually running out because everyone wants distal tibia now for this, which is wonderful. But we're comparing. So myself and Matt, we've looked at our data comparing fresh versus frozen. Hopefully we'll have our paper out very shortly. It's just in the last revisions right now. But in general, we're getting the exact same remodeling. So again, I'm trying to change the phrase because everyone talks about resorption. And hopefully I showed you the model. everything will resorb. You put a bone block in, bone will go away until you get whatever the word is that it stabilizes. So after, what we did find is over 9 months is kind of the time for our frozen distal tibia to stabilize, so we know where it's going to stay for the next several years, and that's really the most important thing. So we're finding the exact same outcomes with fresh versus frozen.
Ivan, I know you use screws mostly, done your technique, and I know you're very good at it. But then you transitioned into buttons and then went back to screws. Can you take us through that?
Yeah, absolutely. So obviously, I do screws. Before COVID, I flew around a lot. I visited lots of center. I really enjoyed Winnipeg with my Jets jersey. But you remember it's not an easy procedure. I didn't figure it out by that time. That was probably 5-6 years into my journey of developing this thing. And lots of people didn't take this on because it does look hard. You're like, how do you get your screws looking that way? Can you really do it without a subscap split? And so most of the time, that's why you see all the publications initially was just to show that it's possible and that the outcomes are good. That's really all I focus on, not on the technique of how to do it. And then, of course, companies come around and then develop this button technique. And Boileau had, highlights how well his ladder shapes work. So I was like, great, if I can use a button, that obliviates the need for the Halifax portal and can make teaching easier. And that's actually where my virtual teaching came in. I started doing buttons. They worked great. Patients got home. It looked great on initial pictures. My first couple of years were looking fantastic. We published our papers on it. And then literally 2 years and 3 days came, my first follow-up clinic for their 2-year follow-up. First dislocation came. And I was like, yeah, it's just one. And then next month, 3 more came. And now we've presented this at Anna a couple times. We're publishing it. It's just going through the last round of revisions right now. But we were getting a 30% failure rate. And I panicked because now I've been teaching people how to do buttons. No question, it's easier to teach. It's more comfortable. You don't have to do the same releases. But you do not get the same fixation with buttons versus screws. Buttons, I know, have been proponent as a rivet. It is not a rivet. Planes don't go with sutures to hold the thing together, but screws are definitely more fixated. And honestly, I think we just happen to only change our technique of buttons to screws, and when we compare them, it's no question our screw outcomes are fantastic. I've gone back to screws for the past, I guess, 6 years. This is the second generation screw. We have never had to remove it because we've now understood how the remodeling happens. We've been able to predict the remodeling, which is really interesting. And now we've actually defined all the releases to make it consistent to be able to teach. And over the past 2 years, I think we just looked at it. We taught 108 surgeons around the world virtually of how to do this.
Amazing.
John, do you have the same fixation techniques? Cannulated screws, buttons?
Yeah, I've moved to similar. I mean, I think the experience that Ivan has had with buttons has pushed me to using screws as well. We were talking about posterior. I think posterior is actually a little bit easier with screws. So yeah, but yeah, screws for me, both the anteriorly and posteriorly.
And anyone using any biologics to stimulate bone growth or healing? No one. Oh, good to know.
No. So I think, again, it depends on if you want. I know we use biologics for a lot of things, but we're using fresh marrow. When we stimulate this down, we burr that bone down, just like you're doing a Latarjet. You got marrow coming out of that glenoid, right? I don't think you need anything else as long as you got very good freshened up bone and you know exactly where you're putting it or how you're putting it there.
I'm going to step in the line of fire here again, but what about the sling effect? Anybody? Maybe Pete. I think I know the answer.
Well, as you know, there's kind of publications going both ways over the years. I used to think that it had a role, but then I actually started doing iliac crest allografts a long time ago, and then noticed the results were actually pretty good. I was doing them open, this for difficult cases, and I just kind of decided that the sling effect probably wasn't significant. And I think that subsequently there's enough evidence in the literature that we can probably say that it's not a critical part of the operation, although some may disagree.
We got one last question. Any panelists using the DASS procedure, DASS, when and how? John, you want to take that one?
Yeah, I haven't had the opportunity to do it. I mean, you'll have to correct me if I'm wrong, but I think we're talking about an arthroscopic allograft procedure to supplement your Bankart bumper. I have not used it. To me, it's been either a bone issue that I've tried to address with bone, but I'm not sure if other panelists have done it.
Yeah, anyone else? No, there's your answer. Well, awesome. Well, this brings us to 9 o'clock. I just want to thank everyone. Dr. Kuhn, thank you for guest moderating. Dr. Woodmass, thank you so much. Ivan, Pete, and John, thank you so much for spending the evening with us. You all can watch this at any time on the Shed or the ASCS websites, but please join us in 3 months for shoulder arthroplasty. So thank you everyone for joining us, and we look forward to next time.
Thanks very
Have a
much,
great
guys.
night.
Thanks,
Have a good night.
Chris.